Our study is titled Long-Term Outcomes of Conservative and Surgical Treatments for Stress Urinary Incontinence, a Retrospective Medicare Claims Analysis. We have no disclosures to report. Research reported in this presentation was funded by an educational program grant from Boston Scientific to AUGS. Statistical support and analysis were provided by the Center for Administrative Data Research at Washington University in St. Louis, which is funded in part by the NIH through the Agency for Health Research and Quality. The statements in this presentation are solely the responsibilities of the authors. Stress urinary incontinence, or SUI, affects a significant proportion of women and can be treated with conservative and surgical approaches. Conservative treatment options include pessary placement and pelvic floor physical therapy, or PT. Surgical treatment options include a midurethral or pubovaginal sling, an open or laparoscopic birch urethropexy, and urethral bulking injections. The primary objective of our study was to compare treatment failure of initial conservative or surgical SUI treatment modalities in a Medicare dataset. This was a retrospective cohort study that used a 5% Medicare dataset, which contained inpatient, outpatient, and carrier claims of women aged 66 and older. The inclusion criteria for the study were as follows: women with a diagnosis of SUI who subsequently received treatment. Treatment could include PT, pessary, or sling surgery, which could either be midurethral or pubovaginal. Additionally, women had to be enrolled in Medicare Parts A and B for at least 1 year and have at least 1 full year without an SUI diagnosis prior to the index code. Treatments in the dataset were identified by corresponding CPT or HCPCS codes. The diagnosis of SUI was confirmed with corresponding ICD-9 and 10 codes, which could include codes for SUI, mixed urinary incontinence, or general incontinence. The index treatment was captured between 2008 and 2013, and follow-up continued through 2016. This ensured each patient in the cohort had at least 3 years of follow-up. In this cohort, treatment failure was defined as a subsequent incontinence treatment after the initial incontinence treatment. For example, repeat sling surgery, birch or urethral bulking after sling surgery, pessary after sling surgery, PT after pessary, or pessary fitting after PT would all be counted as failures. What were not counted as failures included subsequent pessary placement after initial placement, i.e. refitting, or subsequent PT treatment after index PT treatment. Kaplan-Meier curves were used to evaluate time from treatment initiation to retreatment. Analysis was at the person level, and patients were followed from treatment initiation until failure, or the censoring point, death, December 31st, 2016, or 5 years after the index date, whichever came first. In this cohort, 13,510 women were included with an index treatment between 2008 and 2013. The mean age was 76.6 years, and the majority were white. (26% chose physical therapy, 42% chose pessary, and 32% chose sling surgery as their first-line therapy for SUI. This graph is a Kaplan-Meier curve comparing time from initial treatment to time to additional treatment between PT, pessary, and sling surgery. On the x-axis is time in days, and on the y-axis is survival probability, i.e. the chance that a woman receiving one of the 3 initial treatments does not get retreated for SUI. PT is the orange line, pessary is the green line, and sling surgery is the blue line. As you can see, the time to additional treatment was not different between treatment groups. In this table, we have for each of the incontinence treatments studied, physical therapy, pessary, and sling, the events, number at risk, and survival probability, calculated at 1, 2, 3, 4, and 5 years. As you can see, the survival probabilities for all 3 treatment modalities is around 0.9 at 3 years, and this changes minimally as time extends out to 5 years. We then stratified the cohort into 5-year age groups: women aged 66 to 70, 71 to 75, and 76 to 80. This is the Kaplan-Meier curve for the youngest cohort, women aged 66 to 70. Time is in days on the x-axis and survival probability on the y-axis. Pessary is the green line, PT is the orange line, and sling surgery is the blue line. After adjusting for multiple comparisons using the Bonferroni method, sling surgery had the lowest rate of failure when compared to PT and pessary in this youngest cohort. In the 2 older age cohorts, age 71 to 75 on the left and age 76 to 80 on the right, there was no difference in survival probability across treatment groups. In the cohort, many women who chose PT management did end up needing additional PT treatments. And similarly, many women who chose pessary needed pessary refitting. We then performed additional analysis, reclassifying pessary refitting and repeat PT as failures if pessary refitting occurred greater than 180 days later than the index treatment to allow for initial adjustment, or if repeat PT occurred greater than 180 days later to allow for completion of initial treatment course. If pessary refitting and repeat PT were reclassified as failures, sling surgery had the lowest rate of retreatment across women of all ages. The limitations of the study include limitations inherent in claims-based studies, which rely on accurate coding. In our study, we could only define treatment failure as retreatment, and were unable to include other objective or subjective measures of failure. We have no data on which treatment options were offered to patients, and it is possible that the women may have received other SUI treatment prior to enrolling in Medicare, which would not be captured. The strengths of the study include a large database with long-term follow-up of over 13,500 women treated for SUI. The database captured person-level data and thus afforded the ability to follow individual patients over time. Further, it reflects real-world practice and is an important clinical and practice pattern issue. In conclusion, when pessary refitting and repeat treatment are not considered failures, there was no difference in retreatment between pessary, PT, or sling surgery at 5 years. And approximately 90% of surviving patients in each group had not undergone further retreatment. Thank you for your time and attention.